Her passion is working with persons living with ALS. She also developed an augmentative alternative communication program within Orlando Health to better serve the Central Florida area. So please give a hand to Rachel Haines.
Hi, good morning, everyone, and thank you to the ALSA for having me this morning. So we're going to be speaking on dysphagia and ALS. So I'll start by just kind of going over a brief overview of what is dysphagia. So in light, it's difficulty swallowing at one or multiple phases of swallow, and I'll go through each of those phases very briefly with you to better understand just the complexity of our swallow process. I feel that many overlook the complexity of this, but the process itself involves greater than 30 muscles and nerves in order to properly break down the food in our mouth and transport it to the right spot, so to speak, which is our stomach. So the normal swallow function occurs approximately 1,000 times a day. So we have to think about just how often we are swallowing without really even thinking about it. So there are multiple stages that we are going to break down. With persons living with ALS, approximately 85% of those individuals will experience some degree of swallowing deficits throughout the progression of the disease process. Dysphagia or swallowing difficulties can lead to malnutrition as well as aspiration pneumonia. Aspiration pneumonia is something that can develop when a person aspirates on foreign materials such as food, liquid, or even your own saliva. And so aspiration is essentially when that food, liquid, or saliva that has bacteria mixed into it goes down the wrong pipe, as they say, and enters into our airway instead of entering and exiting into our stomach like it's supposed to when we swallow. This increases the risk of death with persons living with ALS by approximately 7 times. So it is something that we shouldn't take lightly and that we should be educating our patients and families on at the onset of diagnosis, even if it's not a bulbar onset, just so patients are aware of those signs and symptoms. So let's break down a little bit further the main stages for swallow function. So we actually start with an anticipatory stage, which isn't listed up here, but that's kind of where if we're self-feeding ourselves, if we're able to still self-feed, that our brain kind of gets excited, our muscles are awakened, even our olfactory systems with smell come into play. So it's kind of prepping us for that food or liquid. And I'll talk a bit more about why working with other disciplines to try and maintain some form of self-feeding for as long as possible is so important for that phase. We then move to the oral prep phase. So this is where the material is chewed up in our mouth, and it forms something called a bolus. So you'll hear that word a couple of more times on this slide. But essentially, that's just saliva mixing with our food to help break it down, and it forms kind of like a ball, I guess you could say, that easily is then transported down, hopefully into our stomachs. And then we move on to the oral phase. So this is where we have that bolus. We use our tongue, we use pressure from our cheeks, all different muscles in our mouth to move that food side to side and front to back. When we're moving front to back, there's a combination of muscle movement, stimulation, as well as pressure generation that kind of allows the pharynx or the throat phase to kind of wake up and say, okay, I'm ready for this bolus to move through. So then in the pharyngeal phase or stage, the airway should be closed or protected, and that happens with a series of muscle movements, including vocal cords, epiglottis, as well as other movements. This helps prevent that material from entering into the lungs, as well as helping it travel through the pharynx or throat and hopefully entering and starting the 4th phase of swallow, which is the esophageal phase. During this phase, muscle contractions occur which can be known as peristalsis. So essentially it's this like wave-like movement that kind of contracts and releases the esophagus and helps push the food material down, eventually emptying into our stomachs. So what causes swallow dysfunctions? I have the main ones listed here, but of course there are some others that are not included. But the main thing I kind of wanted to highlight today is the muscle atrophy, or the weakening of the muscles that affect this bulbar function or swallowing. So you might experience weakness of the tongue or muscles in your mouth, and that might be the first symptom that you experience with swallowing, where maybe it's taking a bit longer for you to chew that material, or move the food or liquid from the front of your mouth to the back of the mouth to prepare for that throat phase. You can also experience weakness of the throat muscles, and some patients kind of initially describe this sensation to me as just food sticking in their throat, and I feel that when it's intermittent, meaning it's not happening with every single meal that you're eating or drinking, patients tend to kind of overlook that symptom because maybe at that moment it's not the most pertinent symptom that's kind of modifying their day-to-day functions. But it is still important to let your team know about this so we can intervene as early as possible. The vocal cords can also be impacted. And so like I had mentioned on the previous slide, vocal cords have a really big function in protecting our airway. So they come together or close off during the swallow process, and then we have something called an epiglottis that flaps over and provides an extra layer of protection over that airway. And so if we also are having an impact of maybe the vocal cords not adducting or coming together as tightly as we'd like, you're more prone to developing aspiration pneumonia. Those vocal cords also have a function in cough, and so cough strength is something that we as speech pathologists are going to assess and work with the team and respiratory therapists to ensure that we could try to maintain that life-saving function for as long as possible. And like I said as well, it's important, even if it's intermittent or maybe the caregiver or loved one or spouse is noticing this change first, to still let your team know, be truthful about it. We're not here to remove food or liquid from your diet. We're here to try and prolong the natural way of eating by mouth and kind of working with you to develop that safe food program. Here's just a list that I compiled of signs and symptoms that are typically associated with swallow dysfunction. As you can see, there are quite a few here, ranging from the most obvious, I feel, is the coughing or choking when we're eating or drinking, or oftentimes patients say, well, I eat and drink fine, but I'm coughing all the time on my own saliva. All the way to longer meal times, as well as maybe just some drooling occurring more often at nighttime or throughout your wake hours. The longer meal times, I kind of wanted to hone in on a little bit because it might not be because your swallow muscles are affected. That longer meal time maybe is because you're having difficulty preparing the food, cutting it up, and also self-feeding yourself. So that's kind of where, and I'll chat about it a bit more on a later slide, that multidisciplinary approach is so important. It's not just the speech pathologist, in my mind, that's treating the swallow function. We also have to get the OT involved, the PT involved for positioning, as well as other therapists. If the managing of your secretions, so drooling or liquid just feeling like it's building up in your mouth, or even the coughing or choking on your own saliva, if that's something that you've experienced, there are many things that we can implement as a team, but definitely speaking to your physician about a pharmaceutical approach to managing those secretions is one of the first things that we try to do as well, just to prevent that saliva from going down the wrong pipe, as they say. Saliva has so much what we call gram-negative bacteria in it that we then have to really talk about oral care and how we can aggressively try to reduce that bacteria, which will largely reduce the risk of you developing pneumonia as well, which is our ultimate goal with swallow. So how do we diagnose dysphagia? Here I have listed kind of the main assessment tools that we might use. On the far left is our gold standard, all the way to just a self-reporting tool. So I'm going to go through each of them very briefly. So with the modified barium swallow study, this is basically an ongoing video x-ray of your swallow function. You're given delicious barium mixed with food or liquid of various textures and possibly various thickness or viscosity levels for the liquid. And it's done in conjunction with a radiologist. And the speech pathologist is going to provide you these trials. And the reason we use the barium, which I know does not taste wonderful for any patient in here that might have had this done, but as you'll see in a video that I'll ask the back to play in just a second, it helps us differentiate what are the structures, what is the anatomy of the swallow, and what is that bolus doing. And so if we could play the video, you'll see, I believe it will be on the left, is a normal swallow, and you'll watch the dark substance as it moves down. And then on the right, they'll show an abnormal swallow. So that goes nicely down, and that enters into the stomach. And now this is going to be a little messier, where that dark substance goes down the front and the back side. Everything going down the front is actually entering right into that person's lungs. And so that's the importance of having that barium there, so we can determine that difference. And kind of come up with a game plan of maybe is there a maneuver we can try, like a chin tuck or a head turn or a thicker liquid or a different texture where that doesn't happen. Then we have something called a FEES, or a fiber optic endoscopic evaluation of swallow. And so this, you don't have to drink barium, but you do have to deal with a little camera that's about the size of like a ballpoint pen. Enter through the nasal passageway, so through one of your nostrils, and it hangs down about mid-throat, right above the vocal cords. There are pluses and minuses to this. It just depends on what it is your therapist and team are trying to evaluate with that swallow process. There is a phase of the swallow that we're unable to see. So during the swallow, there's kind of this like whiteout phase, and we can't see that. But afterwards, we're able to see if there's any leftover substance hanging around your airway, which tells us that maybe you did aspirate during the swallow. What I like about this option for my patients is that it allows me to assess what happens during an entire meal. So the modified barium, which is considered gold standard, and it's gold standard for swallow for a reason, it's so fast though, because we don't want you to have that X-ray radiation exposure for any more than 5 minutes. So it's a really quick snapshot. And sometimes with ALS, it's more of a fatigue-dependent swallow dysfunction maybe to start, where maybe after 25 minutes of eating a meal, your muscles start to weaken, and that's where the breakdown occurs. So we can't always capture that with the modified. We can capture that with the FEES because we're not stuck to a short time frame. Now, most patients don't love a camera down their nose during a meal for, let's say, 30 minutes, but it's doable, and there are some agents we can place on the camera to kind of numb the nostril so it's more comfortable for you. The bedside swallow evaluation is something that's widely used. It can be done virtually, outpatient, or home health option. It gives us some objective data, but there's also a bit of subjective data that goes into this study because, of course, we can't get inside your throat by just giving you food and liquid trials and testing different maneuvers and things out like that. But it gives us a lot of good information, and oftentimes if I maybe question if a person is silently aspirating, meaning there's no reaction, that food, liquid, saliva goes right into your airway, and you don't cough, you don't throat clear, there's really no obvious sign or symptom that that's actually occurring. So I monitor vitals, I make sure oxygen saturation stays stable, your heart rate doesn't elevate significantly during or after a swallow. And if I suspect that silent aspiration, I have a conversation and we refer quite immediately for that modified barium swallow study or the fees. But again, I feel like recommendations tend to be pretty similar, if not identical, when we compare the bedside swallow to a modified barium swallow study. Those recommendations don't necessarily change unless we detect that silent aspiration. And then something I do quite often at our multidisciplinary clinic is something called a 3-ounce water challenge. So it's just a really quick snapshot for me to see how are your muscles handling the small amount of liquid, and how can your muscles work consecutively for swallows. So basically I hand the cup or assist the patient if they're unable to bring it to their mouth of 3 ounces of liquid. We can do this with the cup edge, so that would just be tipping the cup back, or with a straw, if that's how the patient typically consumes their liquids. And the goal is to see if your muscles can react in such a timely fashion that there's back-to-back consecutive swallows. Some patients are like, okay, I've got this, I'm gonna chug it like it's a 3-ounce beverage, and others might have to take their time. Sometimes respiratory comes into play. So maybe it's not so much that the muscles for swallow function are working at a slower pace or not moving in the exact way that they should be. Sometimes they have to break because they're short of breath and they're not quite able to coordinate breath support and swallow function. And so this just tells me if there's a breakdown. So if the person cannot do consecutive sips, if they throat clear, if they cough, any of those major signs, then they fail the 3-ounce water challenge. And then that kind of gives me an indication we need to look at your swallow a bit more closely. And last but not least, I use the EAT 10 a lot, and I'll show you on a later slide what that looks like and how to calculate your score. This is very easily accessible and free online. There are even ones where you just type in your number rating for 10 items and it calculates the score for you. But this is just a good self-reporting tool. Okay. So what can we do about it? What is some of the options for treatment? The first and foremost is the respiratory muscle strength training. So I have some of the devices that I utilize with my patients at clinic shown here. The green one is a newer one. It's the EMST, or Expiratory Muscle Strength Training 75. So that number is just the maximum pressure that this device can be calibrated to. The blue one that looks identical, just blue, is the EMST 150. And this is the one that was utilized in a study that was conducted and published in 2015 by Dr. Emily Plowman, which really gave us as clinicians and you guys as patients some hope with management, I feel, with dysphagia. So this study indicated that it was very well tolerated with persons living with ALS, and actually led to improvements in maximum expiratory pressure, which is important for our cough function and respiratory function, airway clearance, as well as increases in some of these swallowing measures that we were seeing. So if any of my patients are sitting here today, they've probably heard me more than they would like educating them on EMST very early on. Because there does come a point in time where it's no longer indicated for persons living with ALS and can do more harm than good. So I tend to start as soon as the patient comes to me or comes to our multidisciplinary clinic, providing this education and trying to get them on board with doing this therapy, because I know the research is there. I've seen it firsthand of the improved quality of life and maintenance of these important muscles for swallowing, as well as cough. Something that we as the clinician just monitor very closely and work in collaboration with the physician and respiratory team is something called your forced vital capacity, or FVC percentage. And so this, at least with the studies that have been conducted thus far, is not indicated if your FVC percentage is 65% or below. And so that's why it's so important to start earlier than waiting until we really can tell that you would benefit or would have benefited from this, because there is a point in time where we have to either discontinue or say that it's no longer indicated for your level of disease burden. Another thing that I work with patients is developing an oral range of motion protocol or home exercise program. And really this is just designed to get some really good stretches that use more just your own kind of body resistance. There's no added resistance from a device or anything like that that I use, but just maintaining the movement and range of motion of the muscles we use for speech and for swallowing. And I have a whole list, and it's way more than I think most people think, because remember, we have greater than 30 muscles and nerves that are involved in just a simple swallow process. So there's a lot of things that we can do to maintain that function for as long as possible. We also work to develop a safe food program, first and foremost. So this could be a lot of different things. It could be modifying the texture or viscosity, so the thickness of your liquid. It could also be modifying just a mixed consistency. So I tend to start with, let's say someone does have trouble with a brothy soup like a chicken noodle or fresh fruit or something like that. I first try and problem solve, okay, well, can you handle the thin liquid for the soup? And can you handle the soft solid, the chicken pieces and the noodles, if they're separated? So then that person can still have the quality of life if they really like their soup as one of their meals, but we just separate the textures out. Because when we put both textures together, it's that much harder for weakened muscles to maintain the liquid, and while we're chewing and breaking down the solid, typically the liquid will shoot back into our throat before our muscles are actually ready to activate and do what they need to do to protect us from pneumonia. It can also be energy conservation techniques and kind of working with the rest of the team regarding this. Smaller, more frequent meals, also working with the dietitian on what type of oral nutritional supplement would be appropriate for you, and talking and providing a list of nutritionally dense food options, if they're safe to have nut butters, avocado, hummus, things like that that are easy to eat, but in a small amount, we're getting just a bunch of nutrition, fat, protein, calories, all the stuff that we need. And then the pictures here. So these are just some pictures of a PEG tube or a feeding tube that's placed surgically into the stomach. And I feel we tend to talk about this as soon as the onset of diagnosis, because it's not an easy subject for patients and family members to digest, so to speak. So we feel that if we talk as early as visit 1 about feeding tubes, it possibly gives that patient and family a bit more time to think about the options and determine, is this something that I want, or is this something I'm strongly and adamantly against? And then the whole team can be on the same page. We're not here, of course, to force a medical procedure on anybody. We're just here to provide you with your options and provide you with education. I think some common misconceptions about feeding tubes that I hear from my patients and family members is that once that's placed, I can no longer walk around, or once that's placed, I can no longer go out and do the things with my families that I want to do, or once it's placed, that means I'm done eating by mouth. None of that is true. You can get a feeding tube and still go on vacations and still get in the water even. A feeding tube does not take away your ability to eat by mouth, but it's just there to supplement, specifically at first. Many of our patients, when it's placed, it might just be there for medication management, which is a little easier to put through a feeding tube than to maybe swallow a really big pill. And some of the pills out there are quite large. It could just be for hydration. I've even had a patient choose to get the feeding tube placed sooner rather than later because they just weren't a water drinker. They knew that they would never become a water drinker, and it was easier for them to put the water through the feeding tube to maintain proper hydration for that quality of life and energy throughout their day. So by no means is it there to take away your ability, but just to supplement as needed. The nutritional needs for persons living with ALS is so much higher than those without living with ALS. And as that disease progression continues, that nutritional drive goes way up. And so it can become quite cumbersome for patients to get enough protein, calories, fat, everything we need to maintain our weight. The reason maintaining weight is so important is that typically if we have a increased acceleration of weight loss in a short period of time, you're probably losing more muscle than anything else first. And we know that with ALS, that muscle atrophy can lead to disease progression. So our job is to try and maintain that weight, maintain that nutrition, and ultimately maintain your quality of life. So I feel that our patients that do get the feeding tube and get it earlier rather than later have a greater level of quality of life than those that either opt out of getting a feeding tube altogether or wait until you need it. And that's not what we want to do either, because depending on who places it, it could take a month or two to get into GI, let's say, or several weeks to get into IR, or interventional radiology, to place that tube. And like I think I've spoken to quite a bit already is just the importance of the interdisciplinary, or a word I like to use, transdisciplinary approach to dysphagia. It's not just your speech pathologist. It should include your occupational therapist, your physician, your respiratory therapist. Mental health counselors are huge with this process, I feel, as well, and just accepting or moving to a different level of acceptance of the diagnosis of ALS that's so life-changing, not only for you as a patient, but for your entire kind of support system. For example, with a dentist, I've collaborated with some local dentists just to adapt the positioning for chairs so patients are no longer kind of reclined and not flooded with that water as they're doing your cleaning, having an extra set of hands for suctioning, like a tech or a second hygienist, so it's not just one suction in your mouth, it might be several, just to make it safer to get that deep cleaning as needed. And then working with the OT and PT for seating, positioning, and self-feeding tools. This is something that we utilize just to track progression. This is taken from the ALS FSR. This is just the swallow portion. So it's scored from a 4, normal eating habits, all the way down to a 0, meaning NPO or nothing by mouth. And this is something that's conducted for several areas of function just to track that disease progression. The lower your score, the more accelerated the disease process is. And then this is something I use during our multidisciplinary clinic just for me to get kind of a number to rate from low risk of dysphagia and aspiration pneumonia all the way up to a high risk. I use a 6-point scale. One thing through COVID that kind of didn't allow me so much to get a full score, we were no longer able during that short clinic to get a peak cough flow, but we're starting to get back to being able in clinic to do a lot of those pulmonary function numbers. But this is just something that I utilize. And this is the EAT 10 that I mentioned earlier. Hopefully it shows somewhat clearly on there. But what you do is you go through the 10 items listed and you score 0, no problem, all the way to 4 being a severe problem. So the higher your score, the more likely you are actually experiencing swallow dysfunction. Even a low score of 3 or higher is an indication that you should speak with your team about a possible swallow dysfunction and get one of those assessments completed by your speech-language pathologist. These are some snapshots of some references at the bottom that I have. My email address is listed there, so please feel free to reach out if you'd like the PDFs of the items below. I have a compiled list of high calorie, so those nutritionally dense food options, but that are easy to chew, which I think is important for energy conservation when we're trying to get the proper nutrition that we need, that I'm more than happy to share. The ALS Association has some wonderful options online for you as well, but I have the PDF that I can easily send if you have trouble finding it. The one in the middle is kind of FYI on feeding tubes, and then the adjusting to swallow changes and nutrition management with ALS. I have links there as well to the ALS Association, as well as the EMST 75 website. What's great is that this is now covered as DME or durable medical equipment by Medicare, but just the 75 device, so the lower resistance than the 150 that I spoke on. But that's been a good option for some patients that maybe don't have the means to get to a clinic where they can provide this device, because it's about a $60 to $75 device, and of course, we don't feel that anyone should have to pay for that. So utilize that if it's recommended for you. References. Any questions? Thank you, guys. Yes.
Well, 2.5 years ago, my wife had aspiration pneumonia, treated successfully. She's been on a PEG tube ever since. So you talked about bacteria in the saliva. When she's not eating, does the mouth automatically, the saliva automatically always have that bacteria all the time?
Good question. So he asked if we always have bacteria in our saliva, even if we're not using it for food or liquid. Actually, you should be doing even more aggressive oral care, brushing, flossing if able, and cleaning the tongue when you're not eating by mouth, which seems maybe backwards, but when your mouth is really dry, which oftentimes patients that are no longer eating or drinking by mouth complain of kind of a mixture of the buildup of saliva, but also dry mouth at times. When we have dry mouth, the bacteria growth can be accelerated. And you can also still aspirate on the feeding tube formula as well if positioning comes into play there, which I'm sure you've been educated on. But positioning is still key, even if she's going to, or the patient's going to lie down and it's been maybe 60 minutes since they've had their formula, because you can still aspirate on any saliva bacteria in the mouth. So, good question. Any other questions? Yes. She's coming.
If somebody is actually choking, like on liquid or their own saliva, is there anything assistance-wise that can be done to help them?
So if it's a solid substance, unless you can see the material in the mouth, then you can grab it out if it's more in the mouth area. But it's no longer recommended to do a finger sweep because you can actually lodge it further down if it's a true choking episode. I often encourage my patients to continue that cough. If they need assistance to producing a cough, if a cough assist is available, that's a good option to utilize to try and bring up that material. But also some patients, I have a caregiver kind of push down and apply pressure to the shoulders as they're trying to cough, and that builds up pressure below the vocal cords that the patient might not be able to do on their own to kind of help blow that material up a bit safer. And then using the oral suction to remove any saliva or liquid that is brought up into the mouth as well if they're unable to spit is important. But positioning, so you don't want them to go flat on their back, as upright as possible is best. Or if they're lying down or in a bed, elevate at least 45 degrees during the event, or side lying is safest. Any other?
Yes, we use, my wife uses a cough assist machine. And I was just wondering, in this choking process, which happens quite frequently, are there any negatives to using that as a training device, if you will, or something like that?
I'll speak to it lightly since I'm not a respiratory therapist, so I don't want to speak incorrectly to that. In our learning labs, we do have respiratory therapists there that could maybe speak to the parameters of using the cough assist. But from the education I've received from respiratory therapists with our hospital as well as companies is that they might recommend to use it as an exercise 2 to 3 times a day consistently, but it's not harmful or have any negative impact to use it as often as needed throughout the day. And it can actually be beneficial for those diaphragmatic muscles to use it, and it's a safe exercise. I think I'm up on time, but please feel free, let me see if I can go backwards. Please feel free to email me with any other questions that you might have, or find me. I'll be here for a majority of the day. I'll be running the swallowing learning lab that's, I believe, 2 doors this way in the exhibit hall. So please feel free to come find me separately. Thank you guys for your time.